Hello, and welcome to today's episode of the Pediatric Consult. I'm Dr. Paul Bunch, your host for today. I'm in the studio today with Dr. Scott Schwartz from the Cincinnati Children's Division of Pediatric Dentistry and Orthodontics. Today's episode is part one of a two-part series on dentistry. Today's discussion is on dental caries. First of all, welcome, Dr. Schwartz. Thanks for joining us today.
Thank you very much for having me. It's a real pleasure to be here today.
To help our audience get to know you a little better, do you mind giving us a little bit about your background, how you came to Cincinnati, some of your interests?
Sure. So I am originally from the north suburbs of Chicago, and I went to dental school at the University of Illinois in Chicago. My first entree to the state of Ohio was when I came to Ohio State University for a general practice residency, which is a one-year hospital-based residency after dental school. I then made my way a little bit further southeast to the University of North Carolina at Chapel Hill, where I then completed both my pediatric dental residency training as well as a master in public health in health policy and management. I then made my way close enough to Chicago to have my mom come visit, but not close enough to have her just show up for lunch, and came to Cincinnati Children's really for the great reputation of the pediatric dentistry residency program and certainly the hospital as well. And it's been a real pleasure to be here for about 8 years now. It's crazy to think about how time flies so quickly. And I love living in Cincinnati, and I like to go home after work and cuddle with my 3 greyhounds.
Thank you so much for joining us, and thanks for bringing all your expertise. Appreciate it. So as a general pediatrician, we often hear that dental caries are the most common chronic illness in children. But that's where a lot of our knowledge stops. We don't get a ton of pediatric dentistry training during residency. Often, if we're in the ED, we're calling dental with any sort of concerns that we have. We don't spend a lot of time at dental clinics. So would you mind telling us a little bit about dental caries in general? Kind of what are some of the causes? What are some of the risk factors?
Sure. So dental caries is actually the formal term for what we commonly refer to as cavities. It's a condition that's mediated by bacteria, a group of bacteria really that we refer to generally as strep mutans. And before we even have teeth, our oral cavity is already colonized with these bacteria. So they're already just kind of living in our mouths. But as our teeth grow into our mouths, they become non-shedding surfaces. And that is a right place for these bacteria to colonize. And so the bacteria form this biofilm or a dental plaque that sits on our teeth, and left undisturbed, that dental plaque would become increasingly complex with anaerobic bacteria, bacteria that thrive and survive in acidic environments. And so these bacteria are eating the sugar that we eat, and by a byproduct of their metabolism, if we all recall our college biology courses, is lactic acid. And as that lactic acid continues to build up, it dissolves the enamel that is below it. And so if this plaque is left in place for a prolonged period of time, that continued dissolution of enamel is what leads to a frank cavitation in a tooth. This frank cavitation can then create a niche where these bacteria are unable to be accessed by a toothbrush or other cleaning mechanisms, and then thrive and create even larger carious lesions until they reach the dental pulp, which is the neurovascular bundle inside our tooth. And that is where we perceive the dental pain that is associated with the buildup of these inflammatory mediators from these bacteria. So as those mediators build up, it can lead to pulponecrosis, which is then when we see abscesses or facial swelling and things like that.
Okay. And the strep mutans and the other bacteria that tend to cause this, where do they come from? How do kids become colonized with these bacteria?
That's an excellent question that we actually don't know fully the answer to. It is thought in some ways to come from our mother, from part of the birthing process. And so there have been studies that have looked at the difference between children who are born naturally and those who are born via C-section and whether or not they have the same oral colonization. But it also can come from parents who are kissing their baby or licking their pacifier after it falls onto the floor, or eating from the same spoon that their child does. So we get colonized from various places.
And is there any advice as far as telling parents not to do those things, not to clean the passy with their mouth, not to share spoons, or does it not matter in the end?
I would love to say that it does matter, but I'm not going to tell parents to not kiss their baby. And I do think it's probably unwise generally to use your own mouth to clean, various items that you are then going to put in your baby's mouth. But I do think at the end of the day, it's pretty unavoidable.
Okay, great. Are there any other known risk factors for caries, things that put kids at a higher risk?
Sure. So enamel is a very sensitive tissue all on its own, and so it can respond while the tooth is developing to various things. So if the patient is while the patient is in utero, if the mother has a fever or is otherwise sick, that temperature change can cause issues with the enamel that then can lead to it not being mineralized correctly, which then increases the risk for it to get caries. There are certainly other systemic conditions, craniofacial anomalies that would make an individual higher risk for dental caries as well.
Any genetic factors? I often have families tell me, well, I have bad teeth, I have soft enamel, therefore my child's probably going to have that too. Is there any truth to that?
Well, there certainly is genetic factors that are related to that and this whole idea of soft teeth. It really is mediated by diet and hygiene, and diet probably being the higher of those two. And even for people who have these genetic factors that might impact the quality of the enamel in their mouth, or other things like salivary flow that are protective for teeth against caries, really it's such a small percentage of individuals, and even those individuals can keep their mouths caries free.
Okay. And what are some of those diet factors? Like what sort of things are kids doing even from the first year before they have teeth that might put them at a higher risk?
Sure. So it's interesting, starting from the very beginning, breast milk itself for parents or caregivers who are breastfeeding their children, breast milk itself is not cariogenic. It's not going to cause dental caries. But what we do know is that once table food is introduced, then the risk for caries while a patient is also breastfeeding increases significantly. The mechanism behind that, I think, is still under discussion, but we do know that those two things are associated with increased caries risk. As far as other diet recommendations that we would make, it's not just about the foods you eat, but how you're eating those foods. And so, there are lots of children who will grab a handful of goldfish, run and go play, come back, grab another handful of goldfish, and this kind of grazing behavior that takes place. And that's really what's most detrimental to our teeth. So, sitting on the couch with a bag of chips is a nice way to relax, but it's not so great for your oral health because as soon as you take a bite of something that has fermentable carbohydrates in it, it drops the pH in your mouth to 5.5, which is the critical pH for enamel dissolution. And it takes about 20 minutes for that to get back to a neutral place. So this repeated, if you have a bite of something at time 0 and another sip of juice at time 5 and, on, you end up prolonging the period of time that your teeth are exposed to this acidic environment. So I would say the first thing, as far as recommendations that I would make is talking about our eating habits and those grazing behaviors and try to encourage parents or caregivers to have their child eat all in one sitting. Additionally, kind of similar to that, children should be encouraged to drink from an open cup as soon as possible, and by age 2, generally speaking. And so, this idea of sippy cups or bottles should never have anything in them but plain water, for the same kind of idea as the grazing thing. You don't want to have a sip of juice and then just be able to carry that around and sip it at will. So having juice or other sugar-sweetened beverages with meal times only, and in between meals as much water as possible. I think the other kind of misconception about dental caries as it relates to diet is this idea that it's really sticky candy, gummy candy, and that sort of thing that is driving the caries process. But I tell parents, caregivers, that it's really anything that you have to pick out of your teeth. So we're talking chips, crackers, pretzels, all of that stuff is the same fermentable carbohydrates that are in your Sour Patch Kids and fruit snacks. And so they're equally bad in different ways. And so trying to, if we are going to have those snacks, using a dry brush or brushing your teeth after you've eaten with those to remove that debris, or trying to choose non-cariogenic snacks would be my best advice, such as yogurt, cheese, nuts, fresh fruits and vegetables are probably the best options. And get a lot of questions also from caregivers about fresh fruit that also has sugar, citrus fruits that are also acidic, and how that kind of plays into the caries process. And the other nutrients in these fresh fruits and vegetables and the fiber really are offsetting the cariogenic potential for them. So they're great to eat, but raisins, of course, are not the same as grapes. And that dried fruit thing sounds, appealing because it's natural, but the sugar that comes from that and the stickiness is still the same, unfortunately, as fruit snacks and things like that.
That's a lot of great information. So I think a lot of us, when it comes to bottles, we've learned very on to advise parents not to bottle prop, not to give a baby a bottle of formula or a breast milk in the crib overnight, or even a bottle of juice. And I don't think we see that as much as we used to, but it still does happen. Sometimes I get asked from parents about water in the crib or in the bed. Can they have a sippy cup or a bottle of water because they're waking up saying they're thirsty? This happens even with like 1 and 2 year olds. Any thoughts on bottles of water or cups of water in the crib?
Sure. That's a great question. I would say that, from a dental perspective, from an oral health perspective, there's not a whole lot of concern about that. I would say that water is appropriate if that is going to be what's given after you brush your teeth.
Great. So sounds like diet's a big factor when it comes to prevention. Obviously, toothbrushing and flossing and early dental visits are another part of that. Can you talk a little bit about your recommendations on brushing teeth? So when to begin, when to use which type of toothpastes, when to have that first dental visit?
Sure, that's a great question. And a bit complicated for consumers because if you've ever been to the oral healthcare aisle, you know that it is vast, and a lot of different products are available on the market at this time. As far as brushing your teeth, you should brush teeth as soon as they appear in the mouth. The lower central incisors, the 2 teeth in the center on the bottom arch, are the first teeth to grow in around 6 months. And so that is the appropriate time to start using a toothbrush and toothpaste with fluoride. The recommendation from the American Academy of Pediatric Dentistry, or AAPD, is to use a smear of toothpaste under the age of 3. And a smear can be a bit complicated to explain, and so I think that for ease of caregiver information exchange, I would recommend to have enough toothpaste to cover about 2 bristles on a toothbrush. If a patient swallowed all of that toothpaste, the dosage of fluoride in a smear of toothpaste is not enough to cause issues with their permanent dentition, which are forming, or GI upset, which is the major concern with fluoride overdose. Teeth should be brushed twice a day for 2 minutes, ideally in the morning and in the evening. And the recommendation would be to not spit, or to spit the majority of the toothpaste out, or to remove the majority of the toothpaste, but to not rinse afterwards, because that continued exposure to fluoride in the foam that remains in your mouth is beneficial to preventing caries, which is something interesting to get used to if you're not used to not rinsing after you brush. Starting at 3 years old, patients can use a pea-sized amount of toothpaste, and that's enough toothpaste for even you as an adult with your full permanent dentition. So, and again, even if a child swallowed a pea-sized amount of toothpaste at 3 years old, they would be totally fine from a fluoride exposure perspective. There are a lot of training toothpastes that are on the market, and so it's really important to be discerning in what toothpaste you're picking up off the shelf. Unfortunately, training toothpaste really has no anti-cariogenic effect, and so it's really important to communicate to caregivers that they need to be looking for toothpaste that either says cavity protection on it or has the ADA seal on it as well, because non-fluoridated toothpastes are not given ADA approval. So those are some things to look out for as far as brushing teeth. It's important also for parents, kind of getting back to this idea of breastfeeding, to clean teeth after breastfeeding as well. So for children who might be ad lib breastfeeding throughout the night, as a pediatric dentist, I'm not recommending for that because it does raise the caries potential. But if that is something that is going to be happening, there should be some, oral cleansing, either wiping teeth or brushing gently with a toothbrush afterwards. As far as flossing and things like that, our baby teeth are supposed to be widely spaced, so that is ideal. And we don't really need to initiate flossing or things like that until teeth are touching.
And of course, in the office, I'm going to recommend brushing teeth at least twice a day. Sometimes that's not always practical. Some families just can't make that work. Is there any benefit of if they're only going to brush once a day, brushing just in the morning or just in the evening, with, of course, the recommendation they do it twice a day. But if they're going to pick one, is there one that's better than the other?
We get this question a lot. And I would say that if you had to pick one, I would say the evening is the best time. Bacteria thrive. The bacteria that cause caries thrive in a dry environment. And as you're sleeping, you are salivating less, you are swallowing less, you are not functioning as much. And so your teeth or your tongue and your cheeks are not self-cleansing your teeth the same amount. And so what you are eating before bed and what you've eaten throughout the day is just sitting on your teeth at night in an environment that is ripe for caries production. So I would say if you had to choose, I would choose the evening, but certainly my recommendation would be to have it done twice.
And then how about first visit with the dentist? When do you recommend that? And how do those go?
Sure. So that's a great question as well. The first visit recommendation from the AAPD and the AAP is to have a visit either first when you notice the teeth growing into the mouth or at least by 1 year of age. And I think that there is a thought about these visits that we're not really doing anything. We're not, what's there to do on a baby who only has 6 or 8 teeth maybe. But I think the doing part is really focused on education and anticipatory guidance. And so those appointments can be critical for establishing a relationship with with a provider, and to get education on practical ways to brush teeth, to perform oral hygiene at home, what toothpaste to use, diet recommendations, and things like that. So without that visit, we often see kids at 3-4 years old for the very first time, and they have established bad patterns, bad habits, and in many cases have caries already, and we could have done more to prevent those in a previous situation.
And we do fluoride varnish in our office until the patient sees the dentist for the first time. Can you talk a little bit about the role of fluoride varnish in kids?
Absolutely. So our physician partners, our other provider partners are key elements to prevention of dental caries, and the use of fluoride varnish is certainly important there. I think the literature shows that between ideally having 2 fluoride varnish applications from a dentist and 2 from a primary care provider, a physician provider, is going to give the greatest effect for caries reduction in these children. I think getting a little bit back to this idea of brushing and how to go about doing that, especially with young children, fluoride varnish uses the way we approach application of fluoride varnish uses a similar approach. And so, especially in smaller children, I think that it's not beneficial to have a baby sitting up on an exam table with you standing or sitting across from it, trying to get a brush in their mouth and have them cooperate, because they're just going to back away or start crying, that whole situation. So it's better to have much more control of the patient in that moment. And so this is useful for brushing at home, and for fluoride varnish application would be the knee-to-knee examination technique. And for those who are unfamiliar, first, there are plenty of images and videos on YouTube for you to kind of see this in action. But a description of that would be the provider and the parent sitting knees to knees with the patient facing the caregiver, with their legs wrapped around their waist. And then when everybody is ready, the caregiver tips the child back into the provider's lap, so their head is right in your lap, which is exactly how we examine dental patients in the office. The parent can control legs and hold hands. Most babies don't love this position and will begin to cry, which is a great time to take a look at teeth. And so, in our office, if you have them available, using the handle of a toothbrush can help keep that child open, or tongue depressors can help keep that child open. But the real critical component of fluoride varnish application is the technique in which it is used. And it is very important, critical to dry the teeth before you apply the fluoride varnish. If you've ever applied it before, and if you've applied it to a wet environment, you'll see that it just kind of pools in the saliva, and then the child swallows it immediately. And so the drying of the teeth is what gives the resin the ability to attach to the teeth. The moisture, as the child closes their mouth, is what helps secure it to the teeth, and then they're not swallowing all of this fluoride varnish. Just for a comparison, the drinking water that we have coming out of our tap here in Cincinnati is 0.7 parts per million, and one packet of fluoride varnish is 22,500 parts per million. So we don't want kids swallowing a whole boatload of that, certainly not if they're getting that 4 times a year.
For sure. So sometimes despite our best efforts, best advice that we're given to our families, the parents are doing all the advice that we give, or sometimes not, we come across a cavity, we come across a dental carie or a concern for that. So what kind of things are we going to see in the office? Obviously frank decay where, half the tooth is missing, I can notice that. But are there other things we might see on an exam that would prompt us to send a child to see the dentist sooner?
Sure. You mentioned that you can detect frank caries, and I think most of the general population can. But what is most concerning to me as a pediatric dentist is the incipient or the early carious lesion. They do not appear as these large dark holes that we anticipate or that we think of in the common vernacular, but they are these very bright white lesions that often follow the scalloping of the gingival margin. And so the first place that a provider should be looking for dental caries is at the gingival margin where the tooth meets the gums. It is often covered in plaque, so sometimes using a 2x2 gauze to remove a superficial layer of plaque and dry the tooth is helpful in evaluating teeth for incipient carious lesions. That would be a time, A, to strongly consider the use of fluoride varnish, and B, if they don't already have a dental home, to refer that patient to a dentist so that they can have a more extensive management plan put in place.
So we can even use the fluoride varnish we have in our office as an early treatment if we're seeing concerning lesions?
100%.
Great. So what if things are worse than that? What things are we going to see if there's a dental abscess or an infection going on?
If a dental abscess is going to be present, you are most likely going to see it on the side of the gums that is facing you. The buccal plate is very thin on both of our maxillary and mandibular jaw, and so that is the path of least resistance for these infections to find a way out. So you're most likely going to see either kind of a punctate lesion right above the tooth. Sometimes it's in between teeth, and they can range from a very small pimple-appearing thing to very large swellings that would obliterate the vestibule or that space between your teeth and your cheeks. So any time that there is suspicion for an abscess would be an appropriate time for a referral to a pediatric dentist or a general dentist, the dental home. That not all abscesses require antibiotics. So if there is drainage from that abscess, there is no need to prescribe antibiotics for those. If the abscess is well localized and there's not other systemic infections, and you can reasonably guarantee that that patient is going to seek treatment after your visit, in the name of antibiotic stewardship, it would probably be advisable to avoid antibiotics in that moment. But if you notice, signs that the vestibule is obliterated or greater swelling that is now seen extraorally, such that it is approaching the eye, hanging below the inferior border of the mandible, the patient has other systemic signs, they have a fever, trismus or inability to open or close their mouth, the swelling on the outside of their face is warm to the touch, would all be indications probably to go to the emergency department for generally admission to the floor and then IV antibiotics. As far as antibiotic use goes, if you do anticipate using that, the recommendation first line would be penicillin, so amoxicillin or Augmentin, depending on kind of the severity of that. And if a patient has an allergy to amoxicillin, the new guidance is for azithromycin as a second line.
Would not have guessed that. So I think we have a good idea of how to advise our patients to both prevent dental decay, prevent caries, and then what to do when we have concerns in the office. Are there any other tips or tricks or pearls of wisdom that you can share with primary care providers that might help us guide our patients with their dental health?
Sure. So I think a question that comes up a lot is dental pain related to caries. And dental pain is best managed by Tylenol and Motrin. And really no stronger medications are required, and definitely to avoid Oragel. So I think it's important to ask families what they're doing to control dental pain at home, because significant consumption, inappropriate application of, and then swallowing a boatload of Oragel can lead to methemoglobinemia and some other issues. So making sure to guide parents towards Tylenol and Motrin. We generally advise parents to alternate those every 3 hours. So if they give Tylenol, after 3 hours can give Motrin, after another 3 hours give Tylenol, and so that way you have both of those medications kind of overlapping over time. I think that is an important thing to communicate to families who are looking for answers for a kiddo who is uncomfortable.
Well, Dr. Schwartz, thank you so much for your time and expertise today. Just a reminder to our listeners, today's discussion was guided by the Community Practice Support Tool on dental caries that you can find on cincinnatichildrens.org. Also, today's episode is available for CME credit. You can find a link for that in the show notes. And again, Dr. Schwartz, thanks a lot for your time today.
Thank you very much.